Welcome, everyone, to our latest Fireside Chat, where we are focusing on a healthier moms, healthier babies, and a healthier nation. My name is Jenny Bogart, and I am the Executive Director at the National Hypertension Control Roundtable. And I am so honored to be here with today's speakers. I'm going to pass it over to our amazing co-chair, Dr. Yvonne Commodore-Mensah, who will be moderating the discussion today and introducing all of the presenters. In the meantime, if you have any questions, we encourage you to type it in the chat box during the presentations and the Q&A. Yvonne, the floor is all yours.
Wonderful. Thank you so much, Jenny. Good afternoon, everyone. Happy Heart Month and happy Black History Month. I'm so delighted to moderate today's fireside chat titled Hypertension Control, Healthier Moms, Healthier Babies, Healthier Nation. So we know that maternal deaths is considered a critical marker of a nation's health. And unfortunately, the statistics we have on maternal mortality in the US suggest that our nation is unhealthy. The US has one of the worst maternal mortality rates in the developed world, but we also know that there are pronounced disparities in maternal health outcomes, with Black women dying at a rate that's 2.6 times higher than white women. But we also know that deaths from hypertension outcomes contribute substantially to maternal deaths in the US. So I have the unique honor of moderating today's conversation with three experts in hypertension care and women's health. I admire each and every one of them, and they are dear colleagues. And when we started talking about potential panelists, they were the perfect people to invite to this fireside chat. So I'm going to start off by introducing them. They'll give brief remarks on their work and how their organization is working to advance maternal health in the US, and also talk about efforts to improve blood pressure control. And then we will transition to a moderated conversation. I have some questions prepared, but I would love to take questions from the audience. So please feel free to put your thoughts, reactions, or questions in the chat. Jenny will be helping me to moderate the chat box. And so please feel free to engage in this conversation. So let's get started with introductions. First, we have Dr. Garima Sharma. So Dr. Sharma is a national leader in women's health and preventative cardiology. She's the director of the Women's Health Cardiovascular Health Program and the director of the Cardio-Obstetrics Program at Innova Health System. She's the founder of the Cardio-Obstetrics Program at Johns Hopkins, where she and I met several years ago. She's also led several national and international educational conferences on women's cardiovascular health. Her clinical and research interests are in cardiovascular disease, especially among women during pregnancy, preeclampsia, maternal obesity, health disparities. Her resume and CV is pretty extensive, but in the interest of time, one of the things that I will mention is that she's been a member of a number of writing groups on cardiovascular disease and women, and her research has been funded by the National Institute of Health, the American Heart Association, and she's also published extensively in high-impact cardiology journals. And she's also a member of the ACC Women in Cardiology Leadership Council, and also the American Heart Association Council of Clinical Cardiology in women and underrepresented populations. So thank you so much, Dr. Sharma, for being here. Second, we have Dr. Rachel Bond. She's a women's heart health and prevention specialist. She's also the systems director for women's heart health at Dignity Health in Arizona. She's an assistant professor of internal medicine at Creighton University School of Medicine. She wears many hats. She's also board certified, attending cardiologist in Arizona, and has dedicated her career to the treatment of heart disease through early detection, education, and prevention. Dr. Bond is also passionate about promoting the professional development of women and minority groups in the health science profession. She has a passion for advocacy and mentorship, and her clinical interests include heart health promotion and maternal health. She also co-chairs the Cardiovascular Disease in Women and Children's Committee of the Association of Black Cardiologists, where she's leading efforts surrounding Black maternal health. And Dr. Bond is also the spokesperson for the Go Red for Women campaign and also sits on the board of directors. She's also received the coveted Nanette Wenger Award for her work and advocacy in women's heart health. So last but not the least, we have Hilary Wall. So Hilary is a senior scientist in the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention, CDC. So Ms. Wall serves as a science lead for Million Hearts. So Million Hearts is a national initiative that's co-led by CDC and the Centers for Medicare and Medicaid Services with the goal of preventing 1 million heart attacks and strokes by 2027. In this role, Ms. Wall provides scientific leadership and expertise to a portfolio of work related to health care systems change, health information technology, and their intersection with public policy. For the past 20 years, Ms. Wall has generated evidence-based tools, resources, and technical assistance for clinicians, public health professionals, and community-based organizations in cardiovascular disease prevention. So with that, all of you are in for a treat. And so I want to thank and welcome our panelists for joining us today.
Thank you so much, Dr. Commodore-Mensah. This is wonderful. And thank you to the National Hypertension Roundtable and all my esteemed panelists for giving us this opportunity. Thank you, Ms. Bogart, as well for inviting us. Thank you.
Thank you. So with that, we are first going to allow our panelists to share a little bit about the work that they do in this space focused on hypertension control and women's health. I will first invite Dr. Rachel Bond to share a few remarks about the work that she's doing in terms of hypertension control and maternal health. So Dr. Bond, over to you. Thank you so much.
Yes, thank you so much for the opportunity. And I agree. Thank you to my esteemed colleagues that are currently on the panel. I'm very briefly going to go over a very loaded topic and just highlight a few of the aspects of this very loaded topic that I'm so privileged to be part of. So as noted, I am currently the Women's Heart Health Director, and I oversee the cardiovascular sector for women's heart health at Dignity Health in Arizona, but I'm also very privileged to volunteer my time with a lot of cardiovascular societies. And a lot of the work that I'm going to be touching upon is through my work with the Association of Black Cardiologists. And as you'll learn as we talk and touch upon a lot of the questions that will be asked upon us, is that we know cardiac disease as well as maternal health have a very, very consistent intersection. And one thing that for me that's been very passionate is to highlight the disparities that exist. And we know that when we look at the statistics, Black women are dying at the highest rates. We also know that the American Indian and Native Alaskan population are very, very shortly right after them. And for a doctor like myself who works in Arizona, I take care of this very diverse patient population. So a lot of my work and passion has been to hone in on more unique ways we could actually tackle this epidemic that we're seeing. One way that I was very privileged to address was in a publication where I was first author with some of my colleagues within the Association of Black Cardiologists, where we talked about the importance of the maternal heart team. What is the maternal heart team? Well, it's a team led by clinicians that are usually from the cardiology world, the maternal fetal medicine world, obstetrics. Sometimes also we move outside of the scope of that, but we also, of course, include nursing staff, where we often take care of patients across their maternal health continuum. One thing that we wanted to broach upon in our actual manuscript was the importance of including in that team possibly members that you wouldn't think of, the pediatrician, understanding that as early as possible, if we could optimize cardiovascular health and cardiometabolic health, if the child then becoming an adult decides to have a child, they actually would have optimized health, which yes, may not completely erase their risk factors, but it absolutely can help to mitigate that. And similarly to that approach, including the primary care clinician and doctor into the mix as well. The importance of them after the pregnancy, and most importantly, after one decides to no longer have any children, how will that look in terms of revamping maternal health mortality? And one thing that for me has been important is to address the fact that although a lot of the guidances we have out there talk about this collaborative approach, talk about optimizing cardiometabolic health through lifestyle, healthy lifestyle, and going to the clinician and getting your numbers checked, we know that that's not the root cause of why we're seeing these disparities. A lot of it has to do with the system at play. And one thing that I will say is that we know that these statistics exist irrespective of one sociodemographic factor. So the higher risk faced by Black women, it spans income, education, and ideal cardiovascular health. And I was really moved by a quote that I was fortunate to hear after hosting a watch party with the Association of Black Cardiologists on an amazing docu-film called Birthing Justice, which I would encourage all to actually listen to. Dr. Joya Creer-Perry, who is the founder and president of the National Birth Equity Collaborative, she states, Black women who are normal weight, have a college education, and the same wealth as white women are still more likely to die within a year of childbirth than their white counterparts. So we can't buy or educate or exercise our way out of this crisis. The data shows that even when we do all those things, we're still more likely to die. So it highlights a lot of the work that I've been trying to focus in on and a lot of my manuscripts and research and advocacy, which is that the maternal mortality crisis, it's not race, but it's racism. We know that systemic racism leads to interpersonal racism. That leads to negative social determinants of health, which leads to healthcare inequities, and that negatively impacts Black women and mostly women of color. And an aspect of that, which I'm very privileged to have worked with, this was an opinion piece that both myself and Dr. Ansong and Dr. Michelle Albert were able to publish in circulation in last February during Heart Month, talks a lot about how those common stereotypes and the history of disappointment and the spiritual values and the foremother influences, what role that plays on our actual overall cardiovascular health. We know that it increases the stimulation of our systemic nervous system, our inflammatory system, and our hypothalamic pituitary system. And all of that increases our allostatic load and ultimately leads to premature cognitive and cardiovascular health. So it's not probably to me very surprising that those are the patient populations that are having the highest risks of, unfortunately, high blood pressure and other adverse pregnancy outcomes during their pregnancy because of the lived experiences that they're facing. And this is something that we really do need to do a better job in targeting, because we know that the impact of historical trauma is real. It leads to fear, lack of trust, lower self-esteem. And ignoring the fact that implicit bias exists is not helpful, because we know that when there is implicit bias, although some may have access to care, they're not having equal access. And this is why, for me, volunteering at an organization like the Association of Black Cardiologists has been so important. It was founded in the 1970s, really with the intention of improving the health of the Black and Brown and really underrepresented communities. Back in 2020, led by myself, and at the time, my counterpart, who is my chair, Dr. Keisha Gaither, we decided to have a roundtable focused in on maternal health, knowing that there was such an intersection between cardiology and the maternal health outcomes, but more importantly, knowing that Black women were dying at the highest rates. And in that roundtable, we were able to pass that roundtable, endorse the 2020, the 2021, and the 2022 Black Maternal Health Mom the Biz Act, which is really making said change from an advocacy perspective. We also published a lot of the content from that roundtable discussion in Circulation, Cardiovascular Quality and Outcomes in February of 2021. A lot of what we touched upon in this paper, which is called The Working Agenda for Black Mothers, talks about the need to diversify the workforce. It talks about bringing in our community leaders and revamping education. It also talks about honing in on a lot of research efforts in this particular field and the importance of perinatal collaboration, even at the level of the doulas and midwives, who are such an important part of the team. It also talks about professional society collaboration And again, starting the conversation about optimizing our health as early as possible in childhood, as well as even in utero. And through this, we were able to formulate the We Are the Faces campaign. This is a campaign that was launched 3 years ago in partnership with the Oprah Winfrey Network Media, where we wanted to highlight the true faces of Black maternal health. And the first year, ABC members were present. The reason is that they are uniquely positioned to address the Black maternal health crisis as representatives as well as advocates. They are either at the intersection of being either a patient, relatives of patients, or healthcare professionals, or ultimately a combination of all three. And I am excited to say that through the videos, we've also been able to create infographics that provide a plethora of information, a lot of information that would be of value to your patients as you're caring for them, but also from an advocacy perspective, how to begin to advocate for such a very loaded topic, but how it's such an important thing, because that's the only way we're going to actually make changes. So I am so honored again to be part of this conversation, and I look forward to answering any questions that you may have for me in the next coming minutes.
Great, wonderful. Thank you so much, Dr. Bond. So many nuggets here. Love what you said. Racism, not race, is the underlying risk factor. And thank you for sharing all of those amazing resources. So we look forward to the conversation. With that, I'll turn things over to Dr. Sharma, who will tell us a little bit about the work that she does at Innova and has done previously at Johns Hopkins. So Dr. Sharma.
Yeah, great. Thank you so much, Dr. Bond. That was wonderful and very inspirational. And thank you for your work in this field. Thank you for your advocacy. And I'm very delighted to share this space with you. And thank you, Dr. Commodore-Mensah, again. I particularly appreciate this opportunity to talk about something that I do every day. I'm a cardiologist that sits at the intersection of cardiology and obstetrics. And my practice focuses heavily on optimization and management of cardiovascular disease during pregnancy. And I see, and in the postpartum timeframe too. So I see this through the lens of someone who is, very, very deeply involved with the issues that affect pregnant and birthing individuals, as we see. Couple of things that I wanted to sort of bring to the forefront of this panel. This is an important and emergent health problem. Hypertensive disorders of pregnancy account for about 15% of complications from pregnancy in the United States. That number has worsened in recent times. When we look at pre-pregnancy cardiovascular health, pre-pregnancy hypertension is a major factor for poor cardiometabolic health of patients entering pregnancy. Pre-pregnancy hypertension, that is chronic hypertension before pregnancy, has actually doubled from 2008 to 2018. And the highest increase has been in individuals aged 20 to 24 years of age. So this is the youngest birthing population in the US that is already entering pregnancy with a major formidable risk factor, that is chronic hypertension, that leads to preeclampsia, increased risk of preeclampsia during pregnancy. So as we focus on what are some of the opportunities and some of the gaps, I think tackling pre-pregnancy hypertension and optimizing cardiometabolic health, even in the preconception timeframe, is an opportunity. The truth is that many of the birthing individuals or patients desiring pregnancy, people desiring pregnancy, do not really interface with healthcare providers and clinicians in that time space. And so the opportunity is sort of missed even before it is missed, as I would put it. As I see patients transitioning through pregnancy, there are gaps in really streamlining care of the patients. Who manages blood pressure during hypertension or hypertension during pregnancy? How do we titrate this blood pressure? How quickly should we see them? What are some care delivery models that help in optimization, cost effectiveness, efficacy, feasibility, and reproducibility according to health systems? And as we transition our patients who have had hypertensive disorders of pregnancy, how do we safely create a warm handoff from patients, from an OB practitioner to maybe a preventive cardiologist or a family practitioner or an internal medicine doctor or an advanced provider, depending on our practice settings. And I think there's much gap in what are some effective ways of safe monitoring, treatment, early recognition, and effective management throughout the peripartum period. There's a lot of advocacy around this. What works? Self-monitoring versus remote blood pressure monitoring versus remote blood pressure monitoring along with community-based organizations and community health workers, or some sort of innovative models that help reach pockets of communities that are greatly impacted by this. Dr. Bond talked a lot about maternal health in the African American and Black population. It is even more challenging when the Black mother is in a rural setting, where there are maternal deserts, where there's not enough OB care, and a patient has to travel more than 60 miles to get basic obstetrical care. So much of my work, along with Dr. Commodore-Mensah, focuses on identifying determinants of health that impact preconception health. How can we optimize early recognition, better management, and faster treatment of these patients? But more importantly, create safe transitions of care where patients are not lost. They're not lost in care delivery, they're not lost postpartum, and they're retained in our health system for as long as we possibly can retain them, because we recognize that this sort of is a care continuum and doesn't end with the delivery of the baby.
Wow, Dr. Sharma, thank you so much. So many themes came up as you were talking. You touched on the importance of transitions of care, that warm handoff, and how individuals may not interface with a healthcare system. So how do we engage those individuals? So look forward to the conversation later, but thank you for those remarks. So with that, I'll turn it over to Ms. Wall, who will give us a sneak peek. This is really exciting. If you made time to be here today, this is really breaking news. She is going to provide a sneak peek of the Million Hearts Hypertension and Pregnancy Change Package. So Ms. Wall, thank you.
Great. Thanks so much, Yvonne. And, these ladies are hard acts to follow, but I will do my best. And Dr. Sharma, I love hearing implementation science speak from you. This makes me really excited. So I'm thrilled to be here with all of you today and to address this amazing group. As Yvonne mentioned, I'm going to give you a special sneak preview. We are a few months ahead of schedule here when we're going to launch it, but of our Million Hearts Hypertension and Pregnancy Change Package. So next slide, please. I don't have any disclosures, and these are certainly my opinions and not those of CDC. Next slide. So I think most of you are hopefully at least situationally aware of Million Hearts. We're a national initiative. We've been around since 2012, and trying to prevent acute cardiovascular events is what we're really about. And blood pressure control has been a long-standing focus for us. But I wanted to remind folks that in 2022, we actually added a new focus on addressing health inequities among pregnant and postpartum people with hypertension. Next slide. So if you've been part of the roundtable for a while, you've likely heard about the Million Hearts Hypertension Control Change Package. This targets care for non-pregnant persons with hypertension. We have other change packages as well, all related to cardiovascular disease prevention, and all of our change packages use the Institute for Healthcare Improvement's model for improvement that you see on this screen as their quality improvement framework. And so the model just asks users 3 simple questions. What are we trying to accomplish? Those are broad goals. How will we know that a change is an improvement? Those are more specific SMART objectives. And then what changes can we make that will result in improvement? And once you pick your change to implement, you conduct multiple plan, do, study, act cycles. And it's this third question. I think that's likely the hardest for quality improvement teams to answer, but that's where our change packages come in. They provide what we like to refer to as a menu of evidence-based and evidence-informed ways to change care processes. And we've intentionally used change packages as a way to translate the best science specifically for clinical audiences. Next slide. So in May of 2024, which I cannot believe is just a few very short months away, we will be releasing our hypertension in pregnancy change package. This is actually our 7th change package, and this one was co-developed by 2 divisions at CDC, my division, the Division for Heart Disease and Stroke Prevention, and the Division of Reproductive Health, really to bring together hypertension and OBGYN or maternal health expertise. We have also been so incredibly fortunate to co-author this document with a number of clinical societies who are passionate about caring for pregnant and postpartum people. And while I'm not quite at liberty to reveal those organizations right now, we have had some major expertise around the table, and I'm just so thankful for all of their contributions. I also want to acknowledge our amazing external reviewers, including Dr. Bond, who also provided truly insightful and helpful feedback. So our primary audience is outpatient clinicians who care for pregnant individuals, OBGYNs, family physicians, nurse midwives, nurse practitioners, and others. But close secondary audience is absolutely cardiologists, and especially those with expertise like the docs on our call today in cardio-obstetrics. So you'll see tools and resources highlighted from not only the Association of Black Cardiologists, but also the American College of Cardiology. And this change package has over 350 tools and resources that we gathered from 87 healthcare settings who either work diligently to improve care for hypertension in pregnancy or are large organizations focused on this topic. Next slide. So we were very deliberate in our focus on what we're calling hypertension in pregnancy. And I have come to learn that the term hypertensive disorders of pregnancy is often used synonymously for pregnancy-associated hypertension. That includes gestational hypertension, which is hypertension generally developed after 20 weeks of gestation, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia or eclampsia. We wanted to focus on improving care delivered to pregnant persons with chronic hypertension as well, which is hypertension that one either has coming into pregnancy or develops within the first 20 weeks of gestation. And Dr. Sharma spoke a lot about the need to sort of shore up that pre-pregnancy phase of life. And that's why we're really using this broader term, hypertension in pregnancy, to sort of capture that whole continuum. And for those of us who aren't steeped in OBGYN care, for many years, the recommendation used to be that you didn't, for the most part, treat high blood pressure in pregnant persons until it got to 160 over 110 millimeters of mercury or greater. And this is considered to be severe hypertension. And there are so many great efforts and materials aimed at improving treatment for severe hypertension. There are things like the AIM bundles, where AIM is the Alliance for Innovation on Maternal Health from ACOG and HRSA and others, as well as CDC-funded perinatal quality collaboratives. The American College of Cardiology has a whole cardio-obstetrics army that's really tackling these issues. So those are just to name a few who are really dealing with severe hypertension. And then in 2022, a piece was published in the New England Journal of Medicine on the chronic hypertension and pregnancy, or CHAP trial. This compelling study showed that if you targeted a blood pressure of less than 140 over 90 millimeters of mercury in women with mild chronic hypertension, there were better pregnancy outcomes than if you waited to treat until severe hypertension developed. So it's a huge finding. And very soon after that study was published, ACOG issued a practice advisory to help move this evidence into practice. And so our change package is mostly focused on identifying and treating what I'm calling pre-severe, if you will, or mild chronic hypertension, blood pressure between 140 over 90 and 160 over 110. But it's all a continuum, so you will find strategies in the change package related to severe hypertension, mostly focused on outpatient settings. We don't get into inpatient care, but we point you to resources in case that's of interest to you. And certainly we talk about women of reproductive age as well. Next slide. Some of the high-level strategies that you'll see highlighted include one of my favorites, finding potentially undiagnosed hypertension. You may have heard Million Hearts talk about this more broadly as hiding in plain sight. We have been addressing this or attempting to address this for the past 10 years in the general hypertensive population, but I think this is a very applicable concept to women of reproductive age or early pregnancy. So we need to really like take our population health management tools and turn them to that population to find folks who may be who may benefit from being on medication if they're not already. Supporting aspirin prophylaxis to prevent preeclampsia in women at high or moderate risk. This is a very inexpensive strategy that we fear is underutilized. Truth of the matter is we don't have great data in this space, but just sort of anecdotally, when you talk to clinicians, I do think this is an underutilized strategy. And you can get a bottle of low-dose aspirin from that big box store that is sort of all across the country for $4.20. So this, again, is sort of a cost-effective, very cost-effective strategy that I think we could be doing more on. Appropriately using antihypertensive medications, there's a subset of medications for which sufficient safety and efficacy data exists for use with pregnant or lactating individuals. And so it's important to not only make sure we're using those safe and effective medications, but also there's some research opportunities there to gather data potentially on other medications. Self-measured blood pressure monitoring, or SMBP, is something that those of us who work in hypertension in the general population talk an awful lot about, but it has not yet been robustly endorsed by some of the OBGYN societies for a whole host of reasons. But we think it's a good strategy for certain patients. We've heard talk about people who live in rural areas where there are maternity deserts. Like, this could be a really great tool for that population. We do need some more research, though. Many severe hypertension-related events occur in the postpartum period, so educating women and their families on warning signs is so important, as is conveying long-term cardiovascular risk that patients may have because of their hypertension in pregnancy. I think this gets lost, especially after delivery, brains are elsewhere, but we need to figure out how do we improve the system so that the onus is not on the pregnant person to remember this risk that they have, but it's carried through their electronic health record, et cetera. And then lastly, again, we've heard about this, shoring up transitions of care is so important for patients who have hypertension in pregnancy, those warm handoffs that Dr. Sharma talked about. We need that continuity of appropriate care after delivery. Next slide. Just real quickly, this is how the hypertension and pregnancy change package is organized. It's very similar to the hypertension control change package. We've got these 4 focus areas. There's a whole lot of overlap between the two in terms of change ideas and those specific strategies that you can focus on. But I wanted to draw your attention to a few new sections in the hypertension and pregnancy change package. We've included information and resources on delivering respectful care and addressing implicit bias, which our other speakers definitely highlighted, so integral to tackling some of the disparities and inequities that we see. I mentioned appropriate medications, but there are also appropriate laboratory tests that are important for diagnosing the various hypertension-related conditions. And lastly, we have built out a new section on assessing and addressing social drivers of health, which we are really excited about. And those are not specific to hypertension, obviously, and I think that they will have really broad applicability. So lots of great resources there. Next slide, and I'm almost done. I do have a few asks because I'm not just here to talk. I have asks for everyone. Number 1, when the document is released in May, please, please, please help us distribute it far and wide to all of your networks through all of your social media channels, etc. We are also very happy to give presentations on the change package, and we're hoping really to have like a cadre of speakers at the ready. So if that's of interest to your organization, please do let us know. As I've said, this document is really intended for clinicians, but I know public health professionals can use it for quality improvement collaboratives that they host as they have previous change packages. And there's certainly a payer aspect to many of these strategies as well. We just need to flip it a little bit and think, how can payers support this care delivery? I also think many of you are well poised to help fill gaps that our team has identified through the process of developing this resource. That includes tools and resources. There are definitely some change ideas that don't have many tools or resources or any listed and could use some bolstering. There are also some research gaps that I briefly talked about, particularly for SMBP and antihypertensive medications. And we definitely have some surveillance gaps. You know, I mentioned aspirin for preeclampsia prevention. We would love to understand how many pregnant persons at high or moderate risk of preeclampsia were recommended to take aspirin, and then did they actually take it? Like, that would be really important information to know. So I look forward to future discussions with many of you to tackle these important issues, and I hope we can keep this dialogue going well beyond today's fireside chat. And if you go to the next slide, my email is here. Please always feel free to email me. But with that, I will turn it back over to you, Yvonne. Thank you.
Great. Thank you so much, Hilary. So with that, I think our panelists have made it abundantly clear that every mother who dies during childbirth is a failure of our society. And this is an urgent public health issue. And Dr. Sharma shared some statistics earlier. But unfortunately, we know that maternal mortality rates haven't gotten better. They've actually worsened. I would love to hear from the three of you why you think maternal mortality rates have not improved, and what we can learn from other countries or regions that have better maternal mortality rates. Why are we not doing better when it comes to protecting mothers during childbirth?
I can take that in a bit. So, you know, I think there's a systemic issue as to how we collect data. So it starts from both data collection as well as the spectrum of access to care, right? And so maternal mortality is, as we know, is a hard public health metric. It's a metric that is telling us about the commitment to health equity in the country. But maternal mortality, the way we collect maternal mortality data actually lags behind a few years. So having a system where we are actually on point and at point with the most current and most accurate available data is actually a big step in the right direction. Until recently, we still rely quite a bit on maternal mortality review committees in getting that data for us, pooling that data. But there are differences, statewide differences in how maternal mortality review committees actually conduct their officiating. You know, what constitutes a review committee? How are they looking at severe maternal mortality, morbidity? How they're looking at maternal mortality? That needs some amount of homogeneity across the board, and some sort of guidance. And you know, we've looked at the data from the few maternal mortality review committees that have informed us. So when we look at maternal deaths, and this has been sort of published and extensively published by one of our colleagues, Andrea Krianga from the School of Public Health at Bloomberg. And so when are these moms dying? The majority of the death actually happens in the postpartum timeframe. And actually quite a bit of that is after 42 days postpartum. You know, so when we look at where and how to provide care for our patients, I think providing access to care that is well beyond our 60 days postpartum is a given. So now under the Affordable Care Act, you know, there is a press for advancing postpartum Medicaid coverage in most states to at least 12 months postpartum so we can retain these individuals. But then the maternal mortality review committees also looked at what are the reasons for maternal deaths. And so they divided this into patient issues, systems of care issues, and provider issues. So in patients issues, they were not able to recognize signs and symptoms of decompensation, health literacy, health education. In the provider issues, were not recognizing those signs and acting appropriately and having a system of care in place to refer for early referral and prompt follow-up. So I'm thinking about the, you know, physicians that may be missing signs that look like pregnancy, and it can be masked. You know, cardiovascular disease is one of those big maskers. We don't really quite understand it. And then systems of cares issues is where racism, inappropriate care, not providing culturally relevant care comes into play. So those are the, in a nutshell, what we know about why it is worsening. It worsened during COVID, actually. It worsened a lot during COVID, partly because of excess deaths from COVID, right? We know this from the cardiovascular literature too, but also vaccine hesitancy in our pregnant populations. And so better data, I think, will inform us, and being able to create a better system to address this in real time, I think.
Great, thank you. So I heard we need to fix our data structures and collect better data to better understand the scope of this issue. Notwithstanding these gaps, we do know that maternal mortality rates have worsened, and we also need to address issues in terms of systems of care and healthcare access for all beyond the postpartum period. So Dr. Bond and Ms. Wall, any thoughts from you?
I was just going to highlight the fact that, we've seen a lot of improvement. If we use California as an example, they have their California Quality Care Collaborative. And I think even with the improvement where they were able to reduce mortality by 65%, a lot of that was honing in on care bundles that help to actually better diagnose cardiovascular conditions and signs of preeclampsia. But even in doing that, there were still disparities where the Black and Brown community did not have as a robust drop in the mortality rates as their white counterparts of the birthing people and the birthing population. And I think one thing that was very profound in just reviewing the data that they highlighted is that it brings it back to the fact that we have to perhaps start removing and moving away from it just being hospital-based, where we're kind of targeting the impact of what we should be or how we should be caring for these patients, and then actually bringing it to the outpatient practices, whereas Dr. Sharma mentioned, many of these women preferably should be seen, but oftentimes are not because there's gaps in care where a lot of the mortality is occurring in the postpartum. So I think it brings it back to the fact that yes, Medicaid expansion will help, but it's also that education that it's up to that 1 year after delivery where these mothers really should be hyper-focused and being like with a magnifying glass where they're going to be evaluated, because that's where we have the opportunity and potential to diagnose some of these conditions that are largely preventable. I also want to make a point of what Dr. Sharma mentioned, which is regarding the maternal mortality review boards. I will say that not every state has on their maternal mortality review boards a cardiologist. That to me is something that I think without doubt has to be standard of care, because when you think about the leading cause of maternal mortality, it's cardiovascular disease. So that should be standard across the board. But to that point, I do believe that maternal mortality review boards do have to do a better job in actually demonstrating the true sample size of populations. I can speak on this because I live in the state of Arizona, where oftentimes it's very challenging to even get data and statistics on the American Indian and Alaska Native population because they're deemed a small sample size when we know they're not. It's just because we're not actually collecting the data as we should. So there are certain things that I think we can improve that will actually help us to care for these patient populations, but more importantly, the most vulnerable patient populations.
I would just quickly throw in social drivers of health. I do think is a key issue. Obviously, Medicaid expansion is part of that, but we've got maternal deserts all across the country that Medicaid expansion won't necessarily help. So we've got to figure out how to shore up that gap. And then we need to listen to mothers. We need to listen to women. This is the big thing. Women feel ignored and, they're not feeling well and, oh, that's just postpartum symptoms. We need to listen to them. And I'm sure people know about CDC's Hear Her campaign, but this is a real issue, especially for women of color. Absolutely.
And so many examples too. Serena Williams, right? So the point that was made earlier, so money won't protect you, income, wealth will not protect you. So I want us to transition and laser focus on hypertension. So after all, this is a fireside chat for the National Hypertension Control Roundtable. And Dr. Sharma, you shared some striking statistics that chronic hypertension has doubled. It doubled between 2008 to 2018 for those ages 20 to 24. I think someone else or others were struck by that statistic as well. What do we need to do to find those that I think Hilary described as hidden in plain sight? So these are young women who are not perhaps engaging with primary care. How do we find them? How do we screen and how do we treat them appropriately to prevent these complications?
It's the $1,000,000 question, isn't it? Because these folks obviously don't know that they have a hypertension or are not plugged into a system somewhere where their hypertension and other cardiometabolic risks, which usually accompany hypertension, can be managed. You know, and the disparity even widens if you slice it by rurality. So it's a race-based disparity and it's a place-based disparity. And so the rural, African-American women actually perform a lot worse in that and worsening the gap. So talking about what can we do? So, you know, I think focusing this, the problem of hypertension in the context of the entire life continuum is important, right? Because we're focusing a lot of our conversation on hypertension and pregnancy, which is the crux of the problem. But if you're entering pregnancy with chronic hypertension, which is one of the most major risk factors for decompensating, you're much more likely to decompensate despite aspirin use. So I think coming up with a plan where either the pediatricians or adolescent health or some sort of a care model where younger individuals that are entering the birthing phase in their life or the reproductive age in their life, focusing on preteen, adolescent health, childhood health, and focusing on reduction of the cardiometabolic health at that time frame is important. Programs that focus on intergenerational health, mothers' health if impacting early childhood health, programs that focus on early teen assessment of risk, including dyslipidemias and hypertensions. Those kind of programs have a significant amount of value. The problem is that even with those kind of programs, there's still a gap. And so I think where the research may need to follow is what kind of care delivery models can we incorporate, which focuses on addressing preconception health. What are the touch points of engaging patients? How to effectively engage them? As you very well know, Dr. Commodore-Mensah, so much of your work is in hypertension, in younger patients as well. How to effectively engage them, and so that they listen, and how to bring about the importance of life's essential aid, engaging people that are thinking about pregnancy before they're pregnant. I think those are the probably the areas of intervention that I think may make a significant amount of difference.
Great,
So
thank
I'll
you.
just,
Yeah, please.
sorry, I just
Where
jump
can
in.
we find these women?
Yes, and this phenomenon of hiding in plain sight, and as I've said, this is going on in non-pregnant people, so women of reproductive age, absolutely. And I think there's two scenarios: one, people who are in care and people who aren't in care. For really the young women who aren't in care, we've got to think outside of the box. Where are they going? Where might they see a care provider? Is this urgent care? Is this school-based health centers for high school students, college campuses? Like where can we get these messages to women that they need to be attending to their blood pressure even at that young age? I think that's number one. For people in care, we know how to do this. And unfortunately, there's really a paucity of published literature where clinicians have explored this hiding in plain sight phenomenon among pregnant people. Kaiser has a nice analysis that they did that's a little bit older, but it really gives some interesting insights that even in women whose blood pressure was above that severe level, many of them did not get the treatment that they should have. So we're working at CDC to document this in electronic health record databases that we have. And I know there are some other large health systems that are thinking about doing this. So I think drawing attention to the fact that this is an issue and then providing tools to change the systems so that we can use population health management techniques to find these patients and manage them appropriately is key.
Great, thank you. Dr. Bond, anything else to add to that?
No, I was gonna actually just stress that importance of the fact that even when we diagnose hypertension, oftentimes these patients are not being adequately treated. And I do want to mention the fact that we have to go back to kind of the bread and butter, which is physical activity, healthy nutrition, right? And having access to that. And sometimes there are limitations, but trying to work with our patients to figure out what do we have access to? How can we help them achieve those goals? And if we need to modify their medications, that they understand why we're going about doing that. I think that our goal in trying to talk and have these conversations as early as possible, including childhood and adolescence, is because if they do decide in the future when they're older to have children, they already would be optimized, right? That we're not sort of working backwards in a way. And I think that this is where the conversations actually do need to incorporate the pediatricians and the adolescent medicine providers, because they have the power of potentially making the biggest difference. Just knowing that the vast majority of people, when they do decide to actually have a child, are oftentimes in not ideal cardiovascular health. So this gives us that opportunity to work collaboratively with them and start these conversations. And it's not per se just so they achieve good pregnancy outcomes, it's so they achieve good cardiovascular health for the entirety of their duration. So focusing on life course for me is such an important piece of the matter. And I think that's really where, as Dr. Sharma said, the research needs to be focused.
Absolutely. And talking about how we identify these young women who may be at risk, it reminds me of an experience I had with a young woman who was about 24 years old. Blood pressure when we screened her was like 160 over 110. And she said, oh, 2 years ago, the doctors said my blood pressure was 135 over 90, and they told me to keep an eye on it. So this leads me to the question of what can healthcare providers, clinicians, and I like the comment that was made in the chat about the importance of team-based care, how we engage different people, because this work will require all disciplines to work together to identify, diagnose, and control hypertension. So how can the healthcare system and healthcare providers and clinicians do a better job to prioritize blood pressure control in young women?
I mean, we could start with the basics and they can make it a system or practice priority, like get leadership saying, this is something that we need to attend to. I think that is a great first step. I think putting standardized hypertension treatment protocols in place is also a great way to send a signal to all clinicians who might be prescribers that we need to attend to hypertension in a meaningful way. So those were just a few high-level remarks.
Yeah, I also think universal coverage of home blood pressure monitoring devices will make a huge impact. I think that not just in the sense of coverage, but also teaching how to adequately check the blood pressure at home, right? Because that's really the first step for us in terms of diagnosis. We want to make sure that their blood pressure is not elevated just when they come to the doctor and clinician's office, but we also want to follow them along and tweak, if needed, some of their some of the management that we would suggest. So I think that's a pivotal part. The other pivotal part, of course, is as mentioned by Hilary, is to just start these conversations. When somebody has an elevated blood pressure, explaining to them what that means, explaining to them how they can make those modifications. Because by the time someone sees me as a cardiologist, and yes, I focus on prevention, oftentimes they have never had anyone in their life tell them that their blood pressure was abnormal. And when I ask them what's normal, most of the time they have no idea. So that means that these conversations are not happening typically at the basic level, which is usually the first gatekeeper, the primary care clinician. So I really encourage us to have these conversations to talk about what's normal, what's elevated, what's stage 1, what's stage 2. At what point do we need medication? What we can do to modify our lifestyle to actually improve outcomes, and then encourage, hopefully, the insurance companies to cover universally home blood pressure monitoring devices.
Great. So, Dr. Bond, that's a great lead into my question about SMBP. So, Hilary, why isn't SMBP used widely as a strategy for blood pressure management in pregnancy and the postpartum period?
Oh, there's the $1 million question. So I think what it comes down to is, truthfully, there's heterogeneity in many of the studies that we see with regard to the populations that are studied, the outcomes that are assessed, measurement protocols and procedures. Like I've been surprised at the dose that some of these studies recommend for pregnant individuals as they're using SMBP. So we need to like really wrap our brains around what is an adequate dose of SMBP for someone with hypertension in pregnancy. Are we using it to diagnose people or confirm rather a diagnosis of new hypertension? Are we using it to monitor, gestational hypertension or preeclampsia? Like what are we using it for? And so the studies are sort of all over the place. I've also seen there's been in the published literature inconsistent use of appropriate SMBP devices that have been validated specifically in pregnant populations. This is a huge challenge. We've got some resources there that can help guide us, but we need a lot more devices that get tested specifically on pregnant populations. And I also want to put a plug in for arm circumference measurement. This is really key, especially when we have something like pregnancy where there is expected weight gain that will occur. Will that change the arm circumference of a woman, especially if she's on like the cusp end of measurement for a certain size? By the end of her pregnancy, might she need a larger device to get really accurate measurements? This is something I haven't seen explored in the literature, but that's what the kinds of thoughts that pop into my head. So I think we need more research. However, I also know OBGYNs are absolutely using SMBP with their patients. We've talked about rural patients before. How about patients who are unlikely to come in for those prenatal visits? Might they take a blood pressure at home, even if they're not willing to come in or unable to come in because of job obligations, transportation issues, etc. So I think there's a lot of potential here, and we've heard a lot of great examples from OBGYNs and cardiologists in the field that are using SMB with their patients. Lots more to learn, but I think we've got some good supports in place to make this happen.
So I wanted to make sure that I address this comment in the chat about roles for pharmacists, nurses, community health workers. I believe Dr. Bond, you mentioned doulas. So in the last 2 minutes or so that we have, can any one of you speak to the importance of engaging pharmacists, nurses, other healthcare professionals, especially in rural settings? Dr. Sharma, you made the comment about race-based and place-based disparities as well. So how can we work together in terms of teams to improve hypertension outcomes?
Yeah, I really appreciate that question, because I think we have to really expand the workforce, right? In order to actually meet the critical volume that it needs to deliver the care appropriately and timely, we have to really be able to expand our team. And our team has to look different, and it has to look different for different settings. In urban settings, it can have a certain type of makeup. In rural settings, it can have a certain type of makeup. And when there is some intersectionality, it needs to have a certain type of makeup in order to be inclusive, in order to be culturally competent. That's where the importance of relying on clinicians outside the traditional realm of nurses and physicians is really important. And or training individuals from the community, whether they are community health workers from a community-based organization or a faith-based organization. A lot of these faith-based organizations, I'm sure Yvonne, have health ministries. And they do a lot of this extensive public health messaging for hypertension. Having trained people in terms of doula, community health workers that can extend and expand our workforce. Let's not forget the importance of midwives, where they are important and critical, and they are representatives of the community, especially where we can train them and provide them with the resources that we need to reduce the morbidity during pregnancy. So thinking about care models, care delivery models that are inclusive and are representative of the population that it serves, whether it's a pharmacist or it's a setting where barbershops, we have had this conversation where, providing health education assessment in that setting can improve adherence to medications. Similarly, relying on Native folks that are a part of the community carry out this message would be extremely important.
Right. Absolutely. And Unfortunately, we are out of time, and I wish we could continue this conversation, but I do have to say that on behalf of the National Hypertension Control Roundtable, we want to extend our sincere gratitude to Dr. Garima Sharma, Dr. Rachel Bond, and Miss Hilary Wall for taking time out of your schedule to really share your knowledge and expertise with us. And for our audience, thank you so much for being with us today. This wonderful fireside chat will be posted online for those who want to revisit this. But thank you so much, and we hope you enjoy the rest of your week. Take care, everyone. And if you're not a member of the roundtable, please do take a moment to join us.
Thanks so much.
Thank you. Jenny, any final words?
I was typing in our website in the chat box. Apologies for my voice, but thank you, everyone. Thank you to our amazing panelists. Thank you to our inspiring co-chair, Yvonne. Know that the roundtable is launching a working group focusing on this. So if you are interested, please reach out to me. I've already spoke to the panelists about this, but I hope everyone has a great rest of your week. And thank you so much for joining us. Hi, everyone.